Hi, everybody. Today's May 2nd, 2024, and I'm with Dr. Lyle Bohlman, who's been an inspiration for me back in the day. We worked somewhat together or nearby each other, and he's a primary care doctor by history, and I'm not sure exactly what he's up to now, but he's been very interesting in his presentations of primary care medicine. He's got a book out right now as well. Lyle, tell us a little about yourself and what is the journey to and from primary care? Where does primary care stand now in the medical world?
Yeah, I am retired, allegedly, but I've begun to read and write more and more about family medicine and the track that family medicine is on currently. And there's a lot of things happening to try to enhance family medicine and get it back to where it used to be. Not that that's the goal or the ideal, but I realized when I was writing this book and thinking about my past and the tremendous number of different experiences that I had with family medicine, that I realized that people who've trained more recently haven't really had. So I sort of have a unique window into how family medicine was before and where it is today. My father was a family doc and graduated in 1936. I have a brother that's a family doc, retired. He graduated in 1965. I have a nephew that graduated from University of Oklahoma, as we all did, who's a family doc out in Wyoming currently. So I've actually seen and practiced medicine with a whole array of people that were trained in the 1950s, the 1940s, the 1970s. And then for the first 10 years of my career, I practiced out in rural America. And in the rural setting, you sort of pressed into duty to doing everything and anything that walks in the door.
Mm-hmm.
So it was, again, a very unique kind of experience where we didn't have specialists in our town. And if somebody had to go seek specialty care, it was 100-mile drive and an expense. And so it really required a better evaluation of the patient before you thought about sending them anywhere. And I looked at or was able to see physicians trained years ago who were focused much, much more on the patient and their need, the patient and their individual presentation in life, really. Mm-hmm. And those old docs, they knew how to relate to people in a way that we don't really tap into in the way that we train and think about administering medicine today.
Right. So there are a couple of examples come to my mind. So I have not as long, but I have a reasonably long history in primary care. I had my own medical practice, solo primary care, 27 years, and I did done some work since then on a part-time basis, and I had done some work prior to that. So I've got a little more than 3 decades of primary care medicine under my belt. But I noticed as a patient more, because I'm getting older. I'm glad you didn't get older, but I've been getting older. I noticed there's kind of a divorce in eye contact at the very least. And we had a conversation a couple months ago that talked about this. I don't want to go retread this whole thing, but when I've seen doctors lately, are, there's not the facial contact at the very least. Literally they're wearing masks. I mean, even in 2024, both my main doctors are cardiologists and a primary care doctor were wearing masks when they come into the room to see me. Now, mind you, they know me, and I'm not worried about their giving me anything, and they shouldn't worry about my catching anything because the COVID's long gone, and there's vaccines, all that kind of stuff. And so I just kind of feel like, and moreover, on a couple different interactions, they're just sitting facing the wall, typing into a computer, not even talking to me. They're filling in the chart. So it seems like the chart seems to be the patient, and the patient is just kind of ancillary. It's like somebody playing video games. The virtual world or getting that Oculus on your face is more interesting than reality. And we see this kind of a divorce. People, kind of there's more pornography than there are relationships, potentially. People have kind of invested in this virtual world, and it seems like physicians have that same aspect where the virtual world is not, slaying dragons per se, but it's clicking the right boxes and getting their little rat pellets, mouse pellets from the feeder in order to get paid. So they're checking boxes. I mean, literally, and the patient's there as a tool. So my formulation is that a couple different things wrong. A, it's not a genuine service model. If you wanted to buy shoes, I don't know if there's still shoe stores that have shoe salesmen, but if you did, that shoe salesman is somewhat concerned about you and your needs. And there are a lot of shoes in the store, and he's not going to stick one on your foot independent of your desire. I think medicine has that kind of parental aspect where the mommy and daddy is saying, I'd like to take the car tonight and go, to town. It's like, no, you cannot. Go do your homework. Go do this. Go brush your teeth. So I think it's kind of a parental model. B, it's divorced from the consumer model, and C, I think there's from the top down, there's been kind of a military approach to what doctors should and shouldn't say, and we've seen that play out during COVID. So there's a lot there to digest. So I don't know if you agree with any of what I've just said, and maybe again, we're kind of on a short tether today, so I apologize for talking too much. But what has been primary care? What aspects of that were already there baked in the brew? What kind of things can be finished? And I would like to talk about your Farrar article you brought over and maybe put it up so people can see some of the aspects of primary care. How do we, what is it? What's gone bad with it? Was it always this case? How do we fix it?
Well, I think what has happened is we've gone from being a profession to being an industry. And when that transition was made, which I date roughly in the 1980s, early 1980s, when so-called managed care came in. We went from being a profession which deals with individuals' needs and deals with the science and the sociology of applying knowledge, which is sort of my definition of a profession, to an industry. And now, who owns most of everything? Hospitals, pharmacies, pharmaceutical industry, they own pretty much all of medicine. It's very rare that we see physicians, for example, owning their own entity with which they practice. Almost all the entities are owned by hospitals now. We have hospitalists that do things in the hospital with patients, and we have offices now that are mostly owned by the hospital industry. And this change, going from a profession to an industry, I think created the background and the milieu by which this phenomenon you talk about, not making eye contact, entering the quote data, and then analyzing the data becomes the industrial model. And the needs and individual peculiarities of the patient itself is passe. Mm-hmm. And there's a movement now in primary care called direct primary care, where there is a separate negotiation It comes under a lot of names like, concierge medicine, those sorts of things. But there is carved out now a fee that you can negotiate with your doctor to provide your primary care. And we still have the basic model of fee for service. Fee for service type payment moves toward overtreatment, care for populations of patients moves toward undertreatment. And as Farrar points out in his article, one of the big values of primary care, which he defines as family medicine, general internal medicine, and pediatrics, when we utilize that model, we more efficiently match patient need with system resources. And that's a key element, because need is infinite. Patient need is an infinite quantity. The system resources is a finite quantity. And when you look at economics 101, if you have demand versus supply, if your demand is way outstripping your supply, what's going to happen? Well, inflation. And that's what we've seen. We spend more than 3 times as much as any other industrialized nation on medicine, and our outcomes, our measurement of effectiveness, when you look at WHO criteria and that sort of thing, we rank out about number 15. And so we have done this to ourselves, I think, by virtue of the movement from a profession to an industry, and you can't use business model to
yeah, I push back slightly on that. I think we have the NATO problem in American medicine. And when I say that, there are free riders. There are, we have NATO. We are the world's policeman. Maybe not currently, but there's still some auspices of that. But through the Cold War, post World War II, we were the last man standing in the realm of democracy. So we created NATO and CETO and a bunch of these treaty organizations where we are the backstop. And if you've seen baseball, sometimes the backstop gets really pounded. And so we absorb the price, and so we have the great military, and everybody else is kind of like, well, the United States. So they were supposed to pay 4% or 5% of their GDP, the European countries, towards military, and they don't. They pay barely 2%, and they're not really military ready. And maybe England has a few battleships, nobody else does. And so when anything happens, they call to arms, literally, for us. And I think what happened is the same thing on a medical basis, whereas every other country nationalized and socialized their medical aspects. And so there's no real impetus to create any new pharmaceuticals. There'll be no new pharmaceuticals. There probably wouldn't even be Viagra and any of all these new biologic medicines were absent the U.S. healthcare system, for which we pay more. Yes, but we're paying a tax on top of a tax. So Canada, is pretty much the same, morphology as that's kind of America's hat. It's not much, demographically different from us, a little colder and smaller, but they pay very little for the same medications, but they don't develop them. They're developed here. And medications are developed elsewhere, but only solely by the impetus of the U.S. System, which is kind of not fully capitalistic or free market, but less socialistic than the other one. So I think it's a little bit of a system problem there. And I don't know how you get everybody off the back of your truck when you've been carrying them around. This is kind of a social problem.
Yeah, I think that the mentality in the U.S. Is that people, the idea of medicine as a commodity as opposed to a human right. Now, you can argue that one way or the other, but all in all, I was actually watching some YouTube video at the end of World War II, and all the liberation of the concentration camps and the care for tens of hundreds of thousands of prisoners that we took at the end of the Second World War. And the massive requirement for taking care of those people, just getting their everyday needs met, was overwhelming to a system. And I think if we're going to spend a tremendous amount of money, we should at least spread the benefit of that to the whole population. About 28 million people have no form of health insurance in the United States, and more than that have what we would call inadequate health care insurance. So I think our spending should be directed, and what Farrar says in this article is that, and I have really based most of my thought process on his ideas, is that if we base primary care as the basis of our system, rather than just considering it a line of business like orthopedics or like dermatology or like nephrology, it's just one of those things that you buy. It's not one of those things that you buy. It should be the basis of our system. Most every country that has socialized medicine or medicine that treats all their citizens have the proportion of 30% specialist, 70% generalist, as defined by, and it's still that way. And my contention is that we could better spend our money and get more equitable and improve coverage by training 70% of our people to be generalists and 30% to be specialists. And my contention is, since Medicare pays for almost all the medical education in the United States, by virtue of signing a bill, we could change where our training funds go and train 70% or at least finance 70% of our people to be generalists, 30% to be specialists. We'd get better coverage. We would get specialists doing their specialty, which is what they train for. It would be better use of the resources. And I realize it's going to, gouge a lot of sacred cows, but it's the kind of thing that we need to rethink if we're going to change our system to a primary care based versus specialty based system.
Okay, so I'm bored with some of the things you say conceptually, but I think mechanically we differ. I have to tell you, I've engaged with, I think we all do, with the IRS and with city bureaucracies. I own some property, and things come up. You have inspectors and this and that. I have to tell you, where was it? I had a help session. I think it was with TurboTax, whatever. So I've done, just did one quick example, taxes. It was April. We just left. It was the cruelest month, as T.S. Eliot says, not for his reasons. because you have to cough up a big hairball of funds. At least I did. And so I tried to get some information from the IRS, and I tried to get some information from TurboTax. Now, TurboTax is a private company; it's Intuit, and the federal government is not. I'm still waiting weeks later to hear an answer for my query. I'm not going to get into it. The guy from TurboTax, he went above and beyond. He steered me. I mean, he wasn't philosophic, but he was close to it. He kind of gave me a paradigm shift in how I was thinking. And I know it's not medical, but he changed the way I thought about a particular problem, and I looked in different way. It was better than ChatGPT, and he was very informative. And I was blown away. So what's the difference between those two groups? Well, the IRS makes its money regardless of whether you are happy, and Intuit has to keep you happy because there's Tax Act and there's accountants. They have to keep you happy to a certain extent because there's competition. And so, I personally think that medicine will change from competition. They'll change from competition, and it'll be disrupted in ways we can't predict because, as the Danish say, amongst all things difficult to predict, the future is the hardest. And so I think that the future will bring a different kind of primary care, and it'll bring one that's better only if there is a consumer impulse. There's a consumer moment, as I call it, like in the term moment, like momentum, not an instant, but a moment, a push in a physics sense, that people have to have an impetus and a reason for doing the things they're doing. And so, primary care doctors were great in your father's generation because they were fee for service, because they were getting paid for that job. If I had a roofer, the government roofer came along, we'd probably all have the same roofs. We'd have some roof made and it would fit on your house or not fit on your house. That's your problem to deal with it. I call a roofer. I have a choice of 30, 50 different roofers, and they all give me different designs, prices, and all that kind of stuff. And I decide whether I want one or not. So you can have a better interaction if at a shoe store or dealing with help from a company that cares about wanting to make something themselves while they're making something. The aspect and issue of governmental, and again, in a sense, medicine has turned more into kind of a governmental type thing through Medicare and Medicaid and the institutions, whether you want to call it quasi or regular governmental. They have a top-down approach where they're deciding what's right for you. And I think people rebel against that. And they're going to have different modalities through YouTube and chat and all that kind of stuff to figure out things that they want. And they're going to be able to tailor stuff. The DPC model is something about tailoring things to your life. And it really, frankly, it's like private school. My kids went to public school here in Newton, Massachusetts. We were told the best, schools in the world, blah, 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 country. They weren't. They have an institutional model, and they do, they provide some things very well. A lot of things they have no idea about. And if you want things catered to you, you have to go to a place that caters. That's their job. And so, I just think that, you can either go to school, you could have a wedding at the school lunchroom, or you could have a wedding from a caterer. And so that basically people want to be catered to. If you travel cross country on an airplane, you can be in the back or the front. You get there exactly the same time, but people in the front have better service. They're being catered to. Their needs are being met, and they're being looked at, and so forth. And the back, I mean, again, I'm almost entirely fly coach, so I get it. But you get what you pay for, and you pay for what you get. And so people want something, they have to pay for it. But mandating, some kind of different kind of ingredients into the sausage, when you still have the same sausage factory, I don't think that's necessarily progress. That's my kind of thought about it. And I think that medicine will happen in different ways. It's happening right now in different ways, where people are getting the information through YouTube, and they're engaging with people. They're looking out in different ways from the doctor model, and doctors have to figure that out.
Oh, I totally agree that we need a new sausage factory. I agree 100%. And my contention is just what you said. If you go to buy a shoe and the shoe doesn't fit, you're not going to go back to that guy that sold you the shoe. You're going to go somewhere else. And to connect with the need of the patient, you have to train a different kind of attitude in the provider. And people are going to access medicine through thousands of different ways. And all of the technology and the things that, if you look at it, everybody's trying to sell something. Oh, your pulse variability, that is going to determine whether or not you're most likely to have depression or not. Come on. They're selling the device that is measuring your heart variability. Now, there's science behind that, yes, but is there, how does that apply to you, Randy, when you're sitting in front of me and coming to for me to advise you about whatever it is you're worried about?
Right. Well,
And that's the function that we need to train for and we need to fulfill, because if we don't get that, we're just like what's happened now. Those old doctors knew about that. And that's what we do not want to discard from the system. And I'm afraid because of the sausage factory that's been churning things out since 1985 with managed care, that's what we have experienced.
Well, fair enough. I just think there are going to be market answers that we can't predict. I grew up in New York City, and we had these yellow things called taxis, and they still exist. And mind you, they're bucking up against Lyft and Uber and all that kind of stuff. And they make rules and laws so that they can only go to the airport. Or they're trying to carve. It becomes a market thing. So I'm trying to look at this kind of in an economic sense. I'm not an economist, but running my own practice or whatever, I have some kind of sympathies for how things can or should be done. But basically, every taxi industry, if they're yellow cabs, so if they have a medallion, they pay $50,000 or 100, whatever the number was. I assume it went down under Uber, but the whole thing got disrupted because somebody came along with the concept of Uber, and ride sharing and so forth. I think basically you're going to have ride sharing for medicine. People are going to come about getting their information in different ways, and they're going to piecemeal it together, and they're going to find things that sort to themselves. I'll give you one quick example, not quite the same, but literally 35 years ago, a friend of mine was at my house, and she asked me about getting pregnant because she had endometriosis. Excuse me, she had fibroids. I take that back. She had fibroids, and I said, well, get pregnant. You certainly can. There's no reason you can't. She said, well, my acupuncturist says I shouldn't until the fibroids are down. I said, well, look, you're on a time frame, and she was already in her late 30s, or maybe early 40s by that time. Anyway, she. And I said, look, you can do that. Look, I mean, you're asking me my advice. Anyway, she had a whole bunch of medical questions here and there for me. And she always said, well, but my nutritionist, my acupuncturist, but she wasn't that sick. These weren't real medical issues. These were kind of boutique issues. She wanted the answer she wanted, and she got it from the acupuncturist. I'm not saying it's right or wrong. It wasn't a life-changing situation, except for the fact she didn't wind up having a child herself. But people, that's kind of how people operate. They want things they want. And it comes down to life threatening. So I actually said to her at one point, when she kept asking me these things, and then she'd always toss back, well, my acupuncturist said that. I said, look, you know what? When you have, God forbid, when you have, pancreatic cancer or something like that, go see a physician. Don't see the acupuncturist. But until then, till you get severely ill, I guess you're perfectly free to do whatever you want. And that's kind of how people operate. So a certain amount of primary care is, not in the realm of severity, not in the realm of acute illness. It's just a matter of managing this and that. And people kind of want things, and they do it. And maybe they get educated, maybe they don't. But I do think there's a business model there that physicians have to kind of adhere to. Over time, it will adhere to them. I think there are a lot of kind of siloed models that are failing. I think the university model, as we've seen with all the protests and kind of the CRT being taught on campus and the destruction of Harvard and Yale, whatever, from inside out, I think this shows a lot of our institutions are rotten and not fully, I don't mean fully rotten, horrible, I mean rotting, in the sense that they're being decayed from the inside. And I think medicine is going to have to face up with that as well. And they can be supported, like the universities are, through various grants and whatnot and contracts. But over time, I think people will migrate away from those. And I think it's up to physicians to kind of figure out what is, who is their customer and how they best can serve them.
Yeah, if you frame the idea of the interaction between a healthcare professional and a patient as a I don't, what was the word you used, and consumer
Consumer
action.
moment.
You know, at my age, most people come to me. They've been to 14 different specialists, and they come to me. What do you think?
Exactly
Well,
right.
and so they are coming to me because they think I have something to offer them that they're not getting.
Exactly right.
And if we train the right kind of individual, and if we get Black doctors and Latino doctors and Chinese doctors, and we got plenty of Indian doctors, but you know, if we change the milieu and the makeup of the people that uh, administer the primary care or the generalist function, I think that it will go a long way to being that advice model, which is
Yeah.
back more to a profession as opposed to an economic entity.
Well, I don't agree. I think that, you know, it's awesome if people from various backgrounds want to be that thing, but I don't go into an airplane hoping for a Latino pilot. I want a pilot who's competent. And when it comes down to your own retina, and let's say you got only one eye, you got one eye left, one bad eye, you've been in, you know, some injury or whatever, and that eye's going bad. And, you know, you want the ophthalmologist or the retinal surgeon who's really good at that thing. And if it turns out that, you know, I don't know, a bunch of Jamaican Americans have filtered into that profession and they're really good at that, well, awesome. I mean, you go to nail salons, and I don't go to them, but one does go to them, women mostly, and it turns out they're all Vietnamese, at least here. And I think most of the country, they're Vietnamese. And there was kind of a reason for that. I'm not going to get into it. They kind of have these apprentice schools in Vietnam to, you know, get whatever. And so I'm not looking to go to a nail salon. If I did want to get my nails done, I'm like, oh my God, I'm not going to yet another Vietnamese nail salon, but they're really good at it. You know, I'm not going to go find an Egyptian nail salon or something else just for the purpose of that. I want somebody who's really good at my nails. And so you know, the model I think breaks down. I think over time people filter into these professions because they're good at it, and that becomes the demographic of the population. You know, but I'm not going to go into, you know, some other country and, you know, I'm not going to wait. If I'm in Armenia, and I'm not going to say, oh my God, I'm in Armenia, I'm not going to see an Armenian doctor. You know, I mean, that you see what's there, and if people are good at it, that's fine. That's all I really, that's my own criterion about that kind of thing. So I think that it's fine and well and good that people from, you know, various communities work their way up and want to go to medical school, but they have to be good at medicine, and they have to be good at their service and so forth. And I think something that's missing in medicine is this kind of provider interaction, consumer moment, getting rated and so forth, and having people have the choice to choose somebody else. We are pretty much, you know, again, my parental model, we're pretty much given the parents we have. I didn't get to choose my parents. I assume you didn't get to choose yours. And you're given certain doctors and you kind of have to stick with them. And it's not even always the doctor you get to see. I recently had a primary care interaction. I couldn't see my own guy. He had moved out, blah, blah, blah. So I went, I've seen this primary care doctor. I've never seen him. He's a family medicine guy, and he's never like in his own office. I've only seen his nurse practitioners or his PAs and so forth. And I love them. They're very nice people, but they don't have the same level of decision making. They're, you know, doing cookbook stuff, and it's like, you know, they see you, they have an idea. You come in for this, you get that, and they're not able to pivot. They're not able to consider things. So, and I'm being a little bit harsh here. But you know, I think they're intimidated partly because I'm a medical doctor, so it's not going to be the same for everybody. But they defer to me. I say I should do this. There's no real pushback there. So, and it's like, you know, I could cut my own hair theoretically, but I like to have a barber who knows what he's doing, and that's kind of how I roll. But we're kind of rounding out the hour here. Not the hour, the half hour, because we had a little bit of a techno glitch, as you might tell from the different appearance from our show today. But I'm going to give you a chance to, first of all, put up your book, and I'll give you a chance to have some closing words for us.
Yeah, I think that your there's a mixture of truth in what you're saying and truth in what I'm saying, and it cannot be a pure business interaction, in my opinion. And part of, the reason for writing my book and the whole position that I take is that there is something of value in that primary care um, interaction that we can't dispense with. If I could, I would just like to read the last paragraph of my book, because it's, in retrospect, sort of summarizes what what we've been talking about right now. The last paragraph reads, "I believe everyone deserves a personal physician. Something happens in that relationship that can move mountains and change physiology. In times of terror, expertise and diagnostic acumen may not be enough. I believe that personal bond between patient and doctor unleashes an innate neurohumoral response that conjures up an ancient spirit to walk with us in times of distress. It coaxes out the inner strength from the depths of the heart to bridge the gap between what can and what will be." So it's not just an economic interaction that I'm talking about. And the more people that we have vying for the patients at the primary care level, the more we're going to be able to evoke the relationships that create the value of primary care. And if you've never had a primary care doctor that you trust and interact with, then you don't really know what you're missing either.
Yeah, fair enough. Well, I'm sorry that people can't have you as a primary care doctor currently, but I very much appreciate your words. I've enjoyed being with you in person through the decades, and very much now to meet you and see you once again. So I thank you for being on. Hope to have you on again, maybe for some other issues. And lastly, if people want to help support my podcast, they can not just buy Lyle's book, but they can buy my own. It's called Overturning Zika.
Great book, by the way, Randy. I read it. It's good.
Thank you very much. It's The Pandemic That Never Was. And I appreciate that. Any kind words you can leave on Amazon, I appreciate, or pop a review someplace. I'd look forward to seeing that. Thank you very much. I hope you have a wonderful day.
Thank you for having me, Randy.
All right, bye-bye.